Chris and Nancy from 27 Degrees Consulting. We apologize for our prior technical difficulty. This is part of the issue you run into when you try to do this stuff outside of the studio. But because of COVID, we're really trying to be very careful in doing this remotely. So we hope this goes well. We are very happy today to have Dr. Anna Cojocaru with us, who is an expert in pulmonary care and also very expert in the care of COVID patients. And we're going to talk a little bit today about COVID, but also predominantly about the vaccine, which I know there's a lot of interest in. So Anna, why don't we start by just having you tell us a little bit about your background?
Okay, so I am a pulmonary and critical care physician, as you said, Chris. My name is Dr. Anna Cojocaru, also being called Dr. Kojak. I am a lung physician and care for the sickest patients in the hospital, in the ICU. During this pandemic, I was actually the clinical leader of a COVID task team at St. Anne's Hospital, and actually part of a Fall River COVID task team. And then later on, I volunteered to help with sick COVID patients at Morton Hospital, our COVID hospital in the area. I got a team from St. Anne's, doctors, respiratory therapists, and ICU nurses, and we went there for 2 months to help them. And now in fall, with a second wave, we have been taking care of these patients at St. Anne's as well, and also Charlton. During this time, we've been caring for patients at Charlton. So I've been involved in taking care of these patients and learned everything about COVID from February, basically January, February, and then hands-on experience in end of March, April, May. And now in fall, started having a lot of patients in our community hospitals. So that's my background on my knowledge with COVID. Also, I've been treating a lot of outpatients with COVID and learning about new medications and treatments and vaccines and preventative things to minimize side effects and to decrease the spread of this virus. So that's what about me. I've been a pulmonary critical care physician here in Fall River for about 7.5 years.
So I have a couple of questions for you, Dr. Cojocaru. When you're treating outpatients that have been tested positive for COVID, what are you seeing different now than you did at the beginning of the pandemic? Like with the new strain that's out, with concerns, like what's different now?
Okay, so at the beginning of the pandemic, we actually had sicker patients. And also the patients were more scared of this virus that they would come to the hospital all the time to be evaluated because the mortality was so high. Also because we didn't understand this virus and all the consequences of the diseases and how to exactly approach this virus and this disease. So at that time, we used to see more severe patients, and everybody was coming to the hospital. Very rarely that you'll get, like a phone call as an outpatient because everybody was running to the hospital. Now, why they were so sick was because at that time, the viral load that the patients were exposed to, meaning the virus that they got exposed and infected, was much higher, the quantity of that virus, because they did not use a mask for protection. Now we have clear data that wearing a mask, even if you get sick, the load of a virus that you get yourself infected is much smaller, and that translates into milder disease, less severe disease, less mortality. Okay, so we see more outpatients. Patients are more comfortable, and we as physicians are more comfortable to treat these patients as an outpatient because we have some clinical data. We know what are the pathophysiology of a disease. We know and understand, the pathophysiology, and that means that we know also some treatments that may or may not work. We have different data out there, but we do have some clinical studies that shown that a few treatments definitely help. They don't is no miracle cure, but we do have, for example, 2 different medications that have shown to decrease mortality by 30%, and that's dexamethasone and remdesivir. Yeah. And now there are more data coming on other like monoclonal antibodies and plasma that we've been using, convalescent plasma. There's some data there, but we do know that works. And also we've tried other medications like immunotherapy and different immunomodulators. For example, some interleukin blockers like tocilizumab and some other medications. Yeah.
So then I really love the way that you explain that. So we're not getting as much of the germs inside us if we're getting sick this time around compared to last time, and a lot of that's because of the mask use.
Yes.
And then we're positioned better clinically just to know what works versus kind of trial and error that we saw at the beginning of this pandemic.
And also, during this time, now we have 8 months into this pandemic, there are also multiple observational studies in different locations looking at, thousands of patients that are hospitalized with COVID, and look at the other things that, some patients who were more severe or got better, what did they have different, including vitamin D level, including if you're on aspirin. So this is how we came to know that maybe if you're on aspirin, you'll have less chance of getting worse, because that's an observation. We don't know, but we observed patients who are hospitalized being on low dose aspirin, 81 or 25, for some reason, many, less patients were severe disease, less patients were dying. Now we also know that patients who had severe disease, severe COVID, 80% of those patients have very low vitamin D. Okay, so those are things that we learn and pick up, and that's why the direct correlation, meaning if you have high level of vitamin D is going to be protective. But guess what? If it doesn't harm you, we recommend patients to take vitamin D, maybe if there's no contraindication to take an aspirin. Yeah.
Is this a baby aspirin strength or a full strength aspirin?
They looked at 81 to 325. Okay, so even baby aspirin, which is 81, may be protective. I will tell you from other studies that we've had in the past that prevents clotting, 325 is the one that has been shown to decrease clotting. Okay, and this disease, the pathophysiology of the disease, it involves the whole body. Yeah, what is COVID? Is it a viral infection that gets to us, the nose, mouth, goes to the lung? So the first organ to be affected is our lung. And 2 major things in pathophysiology is the start of our disease is windpipe clogging with mucus, because our body ability and response to any infection is to produce mucus in the windpipe, if it's a respiratory infection, so that mucus carries that virus or that bacteria out of the body, makes you cough. So we cough, by cough, we get rid of that bacteria or virus, okay? So in this viral illness, people produce mucus, and you'll hear that people say, but I have a dry cough. The mucus that they found on pathology slides, on autopsies, is not in everyone, but a lot of patients will have very hard, sticky mucus down in smallest windpipes. And that means that when you cough, you're not going to produce mucus, okay? But using methods that will help you to get rid of that mucus will actually may help people to get better. And which are those methods for us is very easy for pulmonary diseases, is to keep body moist. You have to be hydrated. You have to make sure that the air that you breathe in is hydrated and not too dry. Maybe you need to use a mucolytic, that's guaifenesin, that helps to break down that mucus so it's not so sticky and it's easier to be removed, And if people have underlying lung problems or windpipe issues, then the windpipes do not stay constricted and tight to keep that mucus in, but we dilate them. And how do we do that? With inhalers and nebulizers, yeah? And by dilating that bronchi and those windpipes, it releases that mucus. Using Mucinex and staying hydrated, that mucus will release easier and will come out easier. So that's one pathway that we know is affected. Now, the second one that COVID has been affected our body is vasculopathy. We call it. This virus attacks the small cells at the lining of our blood vessels. So that's endothelial cells in our blood vessels. And our lung actually is washed in these small, tiny blood vessels, okay? These are capillaries. And what we found is by disrupting those cells, they produce clotting. So severe disease means small, tiny blood clots into your blood vessels in the lung, okay? And that causes pneumonia. Actually, the typical appearance of pneumonia with COVID is having small little patches at the edges of a lung. And we know now that those patches are actually thromboembolic disease. It's not embolic or microthrombi, okay? So to me, anticoagulation is an important part of our treatment. As an outpatient, if a patient has chest pain and significant shortness of breath, first thing, it's not only first thing, even begin before even they get symptoms. If they're diagnosed with COVID, with this virus, SARS-CoV-2, I review the patient's medical history, talk to them, review their medications. I want to make sure that, if they're Coumadin and Plavix, for example, yeah, they're on other blood thinners, then I would be very reluctant to start them on an aspirin. If they're not on anything, I do ask them to take aspirin 325, discussing with them the risks associated with taking that aspirin. Yeah. Yeah. And then considerations down the line to actually even anticoagulant. Okay. So it's based on the patient risk factors and the doctor's, our confidence and our, ability to manage these patients. So I do that actually for my patients.
Well, I was just going to ask, just comment about the vitamin D issue. How much vitamin D are you recommending to patients?
So
if you just want to take it regularly to try to, prevent or maybe reduce the severity of the disease if they become infected.
Yeah. Yeah. So vitamin D, majority of us are deficient in vitamin D. We know that. And we know from the labs that the normal level of vitamin D is around 25 micrograms or 25 milligrams, something, 25. In reality, it's actually too low. And, you'll hear it from different societies, including endocrinology society, that they will say that a good number is above 50. Okay. And we know that patients is very, very hard to actually overdose on vitamin D. Okay.
Right.
So how about just take 10,000 units? To me, 10,000 units a day, if you take it 2 weeks out of a month, it's not going to harm you. It's good to check that level with your physician. Anybody probably who has fatigue and not feeling well in general, and a lot of physicians, primaries, you guys do that. You check the vitamin D. And I actually check vitamin Ds for the patients who have severe COPD, because that has been associated with worse COPD for some reason. So if patients, complain of fatigue and have significant, I actually check the level and put them on vitamin D.
Yeah, I mean, it's interesting. I've been taking myself about 4,000 to 5,000 units a day, depending on, what I find at the pharmacy. But as you know, I do a lot of nursing home care, and the nursing home population has just been devastated by COVID. And I have a firm belief that a lot of this is related. There's multiple issues, but the vitamin D deficiency is a major issue.
Absolutely.
They're all vitamin D deficient, despite the fact that we put them often on vitamin D, just because they're inside really for their entire life and never get any sun exposure. It's hard to get their vitamin D levels to adequate points. Plus, of course, they're in an enclosed environment, and many of them are not wearing masks. So probably the viral load that they're getting is significant when they're exposed, and they're older and immunocompromised based on that. So I think that's why we see such a high death rate. But I was always fascinated. I've been fascinated by why the death rate has been so high, and I really feel that in the nursing homes, the vitamin D deficiency is a big part of it. So I'm a firm believer that vitamin D is really helpful.
Yes.
I'm glad you say that.
Yeah, and actually one of my friends who's an endocrinologist, I have to give her the credit for this because, you know, I have friends who are physicians and we talk a lot because we love medicine. She told me that, you know, now it's a new kind of a trend in the endocrine society to believe that vitamin D is actually a hormone. Yeah, it's like a hormone because it has so many influences on many other things, including depression and even cancers. Yeah. So I do believe that vitamin D is underrated, and you're right. You know, we need to check and we need to treat, and we just don't expose ourselves to the sunlight. You know, sometimes I don't even know how it's outside until, you know, I go home and the kids or my husband tells me. It's just because you're indoor and you don't have a window even in your office. So.
Plus, we're all using so much sunscreen now because we're concerned, and rightly so, about skin cancer, melanoma, that I think the majority of the population is probably walking around vitamin D deficient, quite honestly.
Yes.
Maybe we can move on a little bit and talk a bit about the vaccine itself.
Yes.
Because a lot of our listeners are really interested in the vaccine and how it works and the risks and et cetera. And I'll let you maybe you can just tell us a bit about your take on this.
Okay. So I'm going to present two different vaccines that they are developing now, or they have one developed. That one is mRNA vaccine, which is the Moderna and Pfizer vaccines. Okay, mRNA vaccine is basically a little piece of information. It's like a molecule that gets inside our body by injection. That molecule carries information of the surface, one little protein that is on the surface of that virus. So if I would be to represent that, you know, you'll see that the virus has on the surface many little spikes, okay? Many little spikes. And it carries the information how one of these spikes is formed. The scientists had to pick which spike actually to be put in this vaccine, not necessarily the spike, but the information. How did they determine that? By researching this virus and finding which spike is stable. What does it mean stable? Basically is like the cornerstone, the foundation, the base of a virus, is the one that doesn't change, is the one that doesn't mutate, is the one that is there no matter what, kind of, you know. So it's less chances to mutate. So when you hear about mutations, they can trick our body by changing the surface, okay? But some of them will not change. So they found this one little piece, let's say, or two pieces that we know that they're not changing. They get that information in one molecule to get inside our body, and then it uses the inside of our cell to start producing that little piece, okay? It makes that little protein from the surface. It's basically like a little piece of is like a little piece from my skin, yeah? So it produces that little thing, and it throws it in our system because our cells, one of the functions that it has is to make proteins, is to make stuff, yeah? So when they find this information, they start making this little protein from the surface of a virus. At that time, our body actually, our immune system, there are different cells that we have in immune system, including, and I'll mention here 3 different cells. One is macrophages. Macrophages are these big, hairy cells that will recognize this little piece and will get around it and will eat it and will destroy it, okay? So that's one type of immune system that we have, and our immune system will recognize and destroy it. 2 other cells that are quite active in immunity like that is T cells, which are lymphocytes, okay? Our white cells that we have in our body, those are your immune white cells. There are different types of white cells. So one is T cells, okay? T cells also will recognize that and will basically tell our body to clean it. by destroying it, will bring other cells to come and destroy that little piece of virus. The good thing about these T cells now, when they recognize this little piece, is that they will get a platoon of T cells to become memory cells. What does it mean is that they will train a few cells to say, listen, you have to memorize this little piece, memorize it. So if this person ever will get in contact with this virus or this little piece in the future, basically when you're going to get the real virus with a little piece on the surface, our cells will recognize it and then immediately will start eating it, okay? Because they already know how to deal with it. So that's the T cells. T cells recognizing and having this memory cells kind of a background. They're long-lived. Those cells live for many years. They go in our lymph glands, they go in our body and just sleep there and are waking up only when they're exposed again to that virus. Yeah?
So,
And
Doctor,
the third cell is B cell. The B lymphocyte is the one that makes antibodies. So that B lymphocyte is going to start throwing these little proteins, that basically are made specifically to basically go just on this protein, and with that, clear it from the body. Okay, and B cells also have memory cells, meaning they're going to recognize it. They're going to kind of figure out how to make that little key to fit exactly that protein. It takes them a while to recognize that. It takes them a while to produce those antibodies. But once they start producing it, they again put a different line, like a platoon of B cells, and say, you are the memory cells now. Now you have to recognize this, memorize this. And when you're exposed in the future to this little protein, you need to throw this antibody in the system right away to clear it. So this is how our body takes care of it. So this is mRNA. Basically, we get a little molecule in our body, makes our cell to produce that little surface protein, and our body is getting ready to actually attack it in the future if we need it. That information, little molecule, is literally being eaten up and destroyed. It does not go inside our nucleus, meaning inside the brain of our cell. The nucleus, which is the nuclei, is the brain and the most important part of inside each cell where our DNA is located. It does not go there, okay? So it does not mess up with our underlying DNA or anything like that. So just to clarify that.
Thank you. I mean, there's a lot of concerns patients have about that, so I'm really glad that you brought that up. Thank you.
So this is the mRNA vaccine that Moderna and Pfizer developed. There is another vaccine actually coming from Johnson & Johnson, which is different. It's not an mRNA, but is a, I have it written down here. Oh, is a protein subunit vaccine, okay? So basically what it does, this one is like straightforward. They got this protein on the surface, this one that I put in here, this little protein, they just inject that into us. It's not gonna make us sick because it's just kind of, they don't get, if I make somebody sick, it's because I'm alive and I can do something, yeah? But if you get something from the surface of my skin, it's just to recognize me, but I cannot kill you with the surface of my skin, basically. The same here, the virus can only do damage if everything inside what's alive goes inside you. If you only take a little piece from the surface, it cannot do anything to you. It can only stimulate your immune system, which is immediate immune system, because this is the part, the surface is the part that is going to be in contact with your body right away when it enters. This virus goes inside my nose or mouth. This little part is going to be recognized. Before this virus has time to go inside my cell to do damage, to do anything, my immune system will be able to recognize just the surface and say, this is it, I'm killing it. I'm not allowing to do any damage. So this is how vaccines will work. And it's pretty safe. People are concerned about the mRNA vaccine because they say we never use something like that, which is not really true. We didn't use an mRNA vaccine, but they did research in mRNA technology in different ways. Actually, with Ebola, they looked to make a vaccine. They looked into flu, actually. In HIV, they did research for this. And they also use this technology for chemotherapy or immunotherapy in cancer patients. And we know that is very safe. We actually transformed the treatment of cancers with this technology. Patients with metastatic lung cancer used to live 6 months. Now they live 5 years because of this technology and this mRNA thing. So I think it's an amazing territory that is quite safe and is changing the face of how we treat diseases.
So, Doctor, I have a few follow-up questions for you. With that, when you said our immune system, we have this memory going on. Does that mean we don't have to get the vaccine every year?
So that's the question that we have to ask. Is this protein, the surface protein, truly so stable that will not change year to year? We do hope that. Now, we know the new strain in UK, which is more contagious, not more deadly, but more contagious. That means that more people can get sick at the same time to overwhelm the medical system, yeah, and the medical healthcare system. So far, the data has shown that is likely preventative. So the vaccine, at this point, we think actually works against that strain because of this surface protein being very stable. Now, is it a cancer that will mutate, that will need a new vaccine? Yes. Okay. Let me tell you, there's always concern about how often will we need the vaccine. This coronavirus, and coronavirus, we call it SARS-CoV-2. Why 2? Because SARS-CoV, which will be 1, was in 2002 in Asia. Yeah. So similar, just not so contagious. Okay. So similar one in Asia. Now we do have some data from there, and we know that 18 years later, majority of people have an immune response when they are re-stimulated. Okay. They still have those B cells. Now, is it adequate? We don't know. Is it enough? We don't know. Is it 100% protective? We don't know. But we do know that they have some memory cells and they start producing again antibodies. This is from observations, actually. And we know about this since spring, actually. Do we have initially, remember that they used to say that we can get reinfected. And in fact, we did see patients who got reinfected. But that's usually people who have weaker immunity. Now, this fall is more data coming on that because in spring we had so many thousands of people getting sick, including myself, who, I had coronavirus in April. We see now that we actually have antibodies. I tested myself 6 weeks later in June. I had antibodies. I tested myself before Thanksgiving. 6 months and a half later, I still had antibodies. And the data now shows that majority of people who were sick in spring, 6 months later, still have antibodies. Antibody is not necessarily, means that, but if you don't have antibodies, it doesn't mean you don't have immunity. Okay. Remember that antibodies mean those little proteins that float in your body from the B cells. If you have memory B cells, memory T cells, that's your immunity. So to test for that immunity is actually more comprehensive test that is not done for general population. That's only for research, but that is going to come later on. Yeah. So I do believe that we'll have long-term immunity. Now, depending how long and depending if it's going to mutate and we're going to need more vaccine or more vaccines that will be adjusted based on those mutations, that's a possibility. And the other question, what I heard is that, patients get reinfected. We had a few patients who got reinfected 3 months later. They were negative, they were better, but their reinfection was very mild, and they were not very sick. Now, what I want to make clear is that a vaccine does not protect you from reinfection, okay? If I get the vaccine, means that my body is able to clear that virus quicker if I get in contact with that virus later on, yeah? It doesn't mean if a virus is on my, got slammed with like dirt on my face, full of this virus, that my body is not going to get it. My body is going to get it. The question is, if I get it again, will I be able to get rid of it quicker? Yeah. So hopefully, yes. And we're not going to get so sick, and we're not going to have severe disease. And that's why I think that even if you got vaccinated, and even if you had the disease, you still have to wear masks, and you still have to use the usual precautions. Because you can still take the virus from somebody else. If I touch my sick patient's face, and with that hand, I touch my face or I touch my kid's face, I'm gonna be transmitting it, yeah? So we just have to be conscious of that.
So I'm going to back up a little bit. I'm glad that you answered so many questions that I had for you during that. Thank you. So basically, when we get the vaccine, it's like we have that little army inside of us of cells that are going to fight. So they're ready. So, if we don't get vaccinated, we don't have that little army on the ground inside of us ready to fight when we get infected. So it gives us a really huge step up. Now, you also said, which I love, that so if I get the vaccine, I'm not like, good, done, don't have to do a mask, don't have to do 6 feet. I'm just like ready to go, and I'm a super person now. So I still have to be careful. I still have to distance myself. I still need to wear a mask because I can still get infected. It's just to a very lesser degree. So, and I'm still contagious with what you just said. It's just.
We don't know that.
Okay.
In principle, yeah, and I can get in touch if I get in touch with a virus again from my patient. And if I go home and don't wash myself, I usually go home, strip everything down, shower, so that you don't bring it to your family, yeah. And in fact, when I was sick, I didn't give it to my family, which is very, very surprising. Not even my husband, my kids got sick.
Okay? That's great.
Still followed those things. I got exposed. I probably got it in my body. When I was coming home, you do cleaning and all of that, and keep precautions somehow in your family. Yeah? So you need to protect them. And as you said, you can get this virus, you get exposed to it. If you have very strong immune system and your vaccine worked very well on you, that boosted that army, then your immune system will not allow the virus to multiply inside you. The back of the throat will not going to make you cough to actually spread it to somebody else. We'll take care of it immediately, and that's it. And you're not contagious. But now, could it be that someone with very, very weak immunity, okay, let's say immunocompromised patient, somebody very old who actually those B and C and those B and T cells are so slow and old, because our immune system gets old too, okay? So they're so slow and old and not responding properly. And maybe the proteins that they make, they're not making, 10,000 antibodies, but they're making only 1,000 antibody per cell, yeah, because they're a little bit slower. It's gonna take them longer to respond to that reinfection or re-exposure, yeah? So could it be that those people will have a little bit of symptoms? Yes. Could it be that their immune system will not be so strong to get rid of that virus immediately? It's possible. It's possible that in the back of the throat, in the nose, inside their throat there, in the windpipes, they'll get some multiplication of that virus. So they could potentially be still contagious. But in theory, as I said, if your immune system is very strong, if you have a good vaccine and good response, and you follow general precautions, continue to do all of that, then you shouldn't get sick, and you should not be contagious.
Doctor, is there anyone who shouldn't get the vaccine? What are the contraindications to getting the vaccine?
Okay, so I get a lot of questions like that. So actually, in fact, yesterday, 3 of my patients who are new patients raised concerns, and I had to answer those. Okay, but only one population who should hold off on getting the vaccine is people who had anaphylactic, I repeat, anaphylactic reaction to previous vaccines. Okay, and that means, what is anaphylactic? It means that they got not local swellness, not chills, not, feeling that they get a rash. If they got so severe shortness of breath that their throat closed, or they had shock, meaning that their blood pressure went down, that they had to be hospitalized and stuff like that. This is absolutely very rare. The rest of the people should get it. And even people with significant reactions to vaccines, like I had a patient who had severe reaction to a vaccine that I gave, a pneumonia vaccine, and I treated her actually a few days in a row in my clinic. I still recommended for her to have it. Yeah, because you can get the vaccine under a doctor's supervision. Who will be that doctor? Will be your pulmonary and critical care doctor, your primary, if the primary is comfortable, and your immunologic, your allergy and immunology doctor. Okay, so we have an allergist, an immunologist at our Prima care, yeah. So when we have many pulmonary and critical care doctors, because we know how to treat reactions, yeah. Immunology, allergy knows how to treat, and we actually do in critical care desensitization to allergies in critical care. Okay, so and we also know how to pre-treat these patients. So in my patients who had some reactions in the past, I would get them for an interview, either televisit. I would prescribe for them some medications or tell them what to do 1 or 2 days before. When they come in my office or will get the vaccine, they'll need to be monitored at least 30 minutes, okay? Because the reaction will be in the first 30 minutes. And then we should have ready things like, EpiPen, steroids to inject them with, treat in case they get a reaction. So that is very rare again. And I have never used an EpiPen or dexamethasone immediately for someone who had a reaction like this. And I've given vaccines for 13 years to patients.
So, a lot of people also have anaphylactic reaction history to, say, antibiotics or other medications. Is that in any way a contraindication?
At this point, that's not considered a contraindication because they are usually allergic to penicillin, yeah, and not to the ingredients. The concern here is that with the vaccine, they're not allergic to the vaccine, but to additives and the things that stabilizes the protein, yeah.
Okay.
So in theory, they say that they should get. Again, should they be careful? Should they do it in a monitorized setting? Absolutely. And at this point, we give a vaccine at the hospital, medical clinic, where they do have physicians and other healthcare providers to monitor and to give them the first response if needed.
Okay. How about what kind of side effects can patients expect to have when they get the vaccine?
Yeah. So side effects from vaccines will happen. In fact, when I got my first shot a few weeks ago, I did get some side effects from this vaccine. And I will tell you that, me and a few other physicians who were sick, we all had kind of the same reactions. And the reactions we had were 1/10 of the symptoms that we had when we were sick. Okay. So basically, this vaccine, if you'll get a reaction, will be very little window into seeing what will happen to you if you actually get the disease. Okay. So very commonly, people get a little bit of pain in the injection site here in the arm where they get it. They'll get fatigue and tiredness. They can get a little bit of headaches, muscle aches. I actually got muscle aches and spasms, chills, some joint pain, and a little bit of fever. Okay, so you can get that, but those symptoms actually get better after 2 days, a day or two, and they go away. It's nothing compared to real disease. And I tell patients this all the time. I get my flu vaccine every year because I had flu when I was 18 in high school, and I thought I was going to die. My parents thought that I was going to die. I was so sick with flu, where you have pneumonia, hallucinations, fevers for 5 days, sweating, nausea, vomiting, and all of those things that actually kill people. Yeah. This virus does something more than that. Okay. I'm a healthy, strong, athletic, lung capacity 126%. When I got this virus, I was down for 2 weeks and another 2 weeks to be able to go to work. Shortness of breath, severe fatigue, pain and muscle cramps to the degree that I was crying. My primary, I came at 7 o'clock in the morning saying, I cannot take this anymore. What can I do? I'm dying. It's like somebody skinned me and pulled the skin and the muscles out of me. Unbelievable pain. And I've had patients who were, down and not getting out of bed and not eating and drinking for days because of the severe fatigue. So, I got my side effect was very little of those muscle pains and cramps. Another physician who had really high fevers and chills to the degree of passing out, he had actually fevers and chills. Another doctor who was, another patient who was, during the time he was sick, he was like out and sleepy and fatigued. He slept for 2 days after the vaccine. Is it so bad? Yes, it's a side effect. It doesn't kill you.
But these are people who mostly had the disease prior. So I think it sounds like they're reacting a little bit more significant. Correct.
More significant. Yeah. But, if a regular person can have something like that, I've had a patient, an older patient who got the flu vaccine a few years ago, and he actually had a fever for 24 hours, high fever and chills. And, I treated him as an outpatient on the phone, Tylenol, and stay hydrated. The wife was there taking care of him. And he got better, okay? It's a significant reaction, but you get better.
I got the vaccine last week, and I was fortunate. I did not have COVID, and my symptoms were incredibly mild from the vaccine. I had a couple hours of the mildest headache I've had. I had maybe 4 or 5 hours of feeling a little tired, and that was it. So, that's probably going to be the experience I'm guessing of most people.
Yes.
Going to be mild. Certainly, worlds better than having the disease itself. One of the questions that came up from one of our listeners was about latex allergies. And this is out in the community a lot. People are concerned about, can they get the vaccine if they have a latex allergy? Can you comment on that?
So I did not research this, but latex allergy is not a contraindication for this vaccine. From what I know, latex is not inside the vaccine.
Mm-hmm.
Anna, sometimes we hear that, talk about herd immunity. With the discussions that you have with your friends and your colleagues, what do they say? Like, how many people actually have to get vaccinated before we kind of think about getting back to normal?
Many more. The herd immunity, it depends, is different on each virus. Let's put it that way. And it depends on how contagious actually that virus is. Yeah. And in this particular virus, in COVID-19, we knew that the herd immunity, we have to achieve about 70% of population to have immunity. 70%. Okay. So ideally, we should have more, but at least 70%. Okay, so what does that mean? That, we have to have 70% of population vaccinated. And how much do we have right now? I actually lost my little piece of that, but in US, I think we're a little bit over 6 million people vaccinated so far. And in the whole world, only 17 million. So in US, that we have over 300 million people, only vaccinated 6. Very little.
It's going to be a little while.
Yeah. And, when we think about when are we going to get our life back, I know that 2 weeks ago, when I had time to look at some of this news about vaccination rate that we have in our country, we were vaccinating approximately 1 million per week. To achieve herd immunity in US, we need to vaccinate 1 million a day.
Oh gosh.
If we want to do that by summer. So we are far beyond other countries, and that's really very disappointing in a way. So we need a better plan from the CDC and Department of Public Health how to distribute. And I think they're coming with something now. The idea is to have that vaccine readily available to all of us and to the general population. And then, of course, we do have stages of who to vaccinate. And eventually, we are talking to have this vaccine in pharmacies.
Great.
Yeah, to give it to everyone.
It's been really disappointing how slow this has occurred. In Rhode Island, for example, they're vaccinating 1% of the population per week, which means it will take 2 years at that rate to vaccinate all of Rhode Island, which we really can't afford to do. This needs to be stepped up. I want to ask one more question that I've heard a couple times in the office. I know the answer to it, of course, but I want you to get this out to the population out there who are listening to us. I have women who come in and say, I'm afraid to take the vaccine because I will become infertile. Have you heard that asked before? I mean, I know it's not an issue. However, I've had a number of people raise that, and I'm not really sure where that information came from. I'm sure it's some dark place on the internet, but it's out there. So I thought we'd address it.
So let me comment a little bit on that. So how I explained that mRNA protein and that technology gets inside our cell, in the liquid of our cell, which is called cytoplasm. Yeah, it does not go inside our DNA or our cell, the DNA or our genomic, let's say, genetic information does not go there and cannot influence in any way, our genome, our ability to be fertile. It has nothing to do with that. And in fact, I don't see how that will go into play, from here to the muscle and going all the way immunity down to the hormonal levels. It doesn't really activate our hormones in any way.
Right.
And it doesn't go to the DNA. It doesn't shut down our, hormonal, is not influenced at all. And in fact, they say that, was it 15 or 20 females who were in the studies in Pfizer and Moderna vaccine, they got pregnant and there were no issues.
Right.
Yeah?
I just wanted to bring it up because I'm trying to bring up all the barriers that I hear from patients. And, a lot of this. I have a latex allergy. I had anaphylaxis to penicillin. I'm afraid I'm not going to be able to have children, those types of things. So I really appreciate clarifying all of that.
I think too, Chris, with that too, it's like some people think that, I already had COVID, I don't need to get vaccinated.
You do. So the reason why you need to to be vaccinated is that when we have COVID, that virus cell with all the surface information is being destroyed, and our body memorizes 1,000, 1,000,000 different pieces of that virus. Okay, which is great. But in order to be effective to actually neutralize that virus, meaning to wash it right away, what you need is just the surface recognition. You need the surface recognition because then when your virus comes and in contact to your cell, immediately is being surrounded by these cells because it recognizes that surface. Yeah. So these vaccines will basically stimulate hard our immune response against the surface to have the first ability to neutralize, to engorge and wash it out of our body. That's the most effective way to get rid of it. And also long-term immunity will be stimulated harder with that, meaning that those memory cells, T and B cells, T is for cellular destruction, where different cells will come and eat it, and B, for the antibodies, for the little proteins to come and surround it, that will be stronger. And that's why it's recommended for everyone. And I got it, and all of us are getting it.
I mean, it's a really impressive vaccine. I mean, we haven't had
Yes.
a vaccine that's been 95% effective that I can recall. The flu vaccine in the older population is at best 60%
Yes.
effective.
Yes. And, just to give you some data, I actually wrote down some, in Moderna, people say, oh, they didn't do all the studies and they rushed it. It's really not like that. Moderna had 30,000 people in the trials, and in two arms, one with vaccine and one without a vaccine, meaning with placebo, they had just water injection or saline. And in the vaccine group, 0 people got sick. 0, no side effects, no major side effects, but 0 people got this virus and COVID. And in the placebo group were 30 people who got sick, okay? In Pfizer, they actually had more people enrolled. They had over 45,000 people, and 170 got sick. Many more got sick because it was in Europe, I think, and it was the beginning of a pandemic. They used it in April, and out of 170, okay, only 1 was in the vaccinated group. The rest, 169, were in the non-vaccinated group, and out of those 170, 10 people had severe disease. So that's very important to keep in mind. This is for people who got the vaccine and didn't get the vaccine. So getting the vaccine, it's so much more protective. It's like 0 in one group and 1 in the other group. So yes, 95%, this is calculations, but in theory, very few people who will get further sick. And actually nobody died in the vaccine group. And it's pretty safe. They actually had about 15 teenagers, ages 16 and 17, who had absolutely no side effects. It is recommended in everyone over 18, but as I said, Pfizer included 15 children they wanted, I guess, ages 15 and 16. And in fact, 15 teenagers, I am lying, 150 teenagers, ages 16 and 17. And in fact, I'm planning to vaccinate my 16-year-old when that will be available for her age.
Great.
That's great.
It's an incredibly exciting vaccine. I mean, I
Yep.
just hope people who are listening to this realize that the side effects are minimal.
Yep.
This is life-saving. It's the only way we're going to eventually get back to our normalcy in life. And really, whatever concerns you have, I hope we accept that they're really not great concerns, unless you've had anaphylaxis to a vaccine in the past, and even that, as Dr. Cojocaru mentioned, that can be probably worked around also in many instances. So
That's right.
almost everyone really seems correct.
Can I mention one thing? So I wanted to mention that if you see, I don't know if our listeners and viewers will see my name here, Dr. Kojak. If you go on drkojak.com, you'll see my website. I actually have a web page. I just started recently on patient education about COVID. Also, I'm just here to say, please get everyone vaccinated in your family, your neighbors, convince everyone. I have been traumatized, literally traumatized from taking care of patients who are dying. I had 30 years old, 40-year-old who died in my hands. We resuscitating and trying to get them better. I called the husband of a 40-year-old and the 7-year-old daughter picked up. That was 8 months ago. I still remember her voice. This is very painful. You don't realize how hard it is for us. Last week, I worked in the hospital. I was coming home after 14 hours of work, and I was crying. My mom took me to the church because I had to stay down in church and pray and hope that we're going to get better. My patients that I took care for many years here in my community, I had 2 patients who died last week in the hospital. It broke my heart. One of them who was a veteran, one of them who who was a firefighter here in our community, who barely had any lung problems, and he died after weeks on ventilator.
Yeah.
I put my heart into taking care of him. My colleagues did the same thing, trying the best things we have. Couldn't bring him back. Couldn't bring him back. And this is going to happen over and over again unless we vaccinate everyone. We vaccinate everyone. And hopefully, if we do that by fall, maybe we can have small family parties. Parties meaning, my mom and my grandmother to come over, or having mass and stuff like that, okay? Maybe we'll be safer because I'm not going to be afraid to put her at risk to have this virus to die. This is devastating, but, it's very hard for us to take care of these patients. And I just wanted to pledge and ask everyone to get vaccinated.
It is. I agree. I mean, for those out there who may think that it's not a real disease or not severe, I mean, anyone who is in the medical field, like yourself and myself, we've seen just lots of really sick people in the nursing home. Particularly, at my home, I've had over 40 people die. Not all my patients, but probably about 20 or so were mine. It's just really very sad. And in the community, I've seen a number of sick people. And fortunately, in the community, I've only had a couple of my outpatients die, but it's just devastating. And I think the only way we're going to really fix this is we need to get vaccinated. And all of these concerns that are out there on the internet, really from unreliable sources, please don't pay attention to them. Listen to medical professionals. Go to the CDC, speak to people who really know what's going on. Don't listen to all this garbage on the internet, because if we don't get people vaccinated, we're going to be dealing with this 2 years from now, and we don't want that.
We don't want that, because we're going to burn out, and, and it's not going to be good for anyone, not for the economy, not for the health of our mental health of our community, not for general health, because now what happens, people stay more at home, we eat more, we're depressed, we were stressed, and all of that will have long-term consequences on our health. And Absolutely. It's so important to take care of each other. This is one time in lifetime, maybe some people never get to have something like this, where we as a community and as a society have to be on each other's side and help each other. This is the time that we have to help each other. And the only way to help each other is to wear a mask, follow the social distancing, vaccinate, and bring everyone to get vaccinated. I pledge every single day, each patient of mine, to convince them, and so they can convince our family members to do it.
Yeah, I talk to every one of my patients every day about it. And, the majority of patients are looking forward to the vaccine. Yes. I end up in very long conversations with a number of patients who, have read misinformation on the internet and have concerns that are unwarranted. And I try to convert them over, because realistically, I don't want this to go on forever. As a doctor, you can say the same thing. This is exhausting. And it's sad to see what's happening to our society. We need to fix this. And this is really the only way out.
Yeah. And, Chris, as you said, you had 40 patients dying in the nursing home, but you care for these older people. People don't realize that you connect to this family, to these patients. You're connected. You've been taking care of them for years. You know their families. Their families may be your neighbor down the road. You know them from the community. And we suffer. We suffer because we don't have the tools and everything we need to get them better. Yeah, we have some tools, but prevention is the best medicine. We know that. So vaccine is the number one thing that we have right now, and we should all take it, because that will make them healthy, the society healthy, and us, better in a way that we're going to see that, our patients are doing well. That gives us, it lifts us up to see how patients are doing good and overcoming this. It's just so important to us.
Absolutely. I absolutely agree. So we may be getting to the end of our talk here. Nancy, did you have any other questions that you wanted to bring up?
I don't want to bring up any other questions, because I'd really love to end on that fantastic, strong message from Dr. Cojocaru that passionate plea to please get vaccinated. I think that's the message we want to end on. And that, thank you so much for your expertise and your knowledge and just getting the word out there and making our community healthier.
Thank you for having me.
Yeah, thank you so much for joining in, and I think this has been really helpful. This will be available on our Facebook page, 27 Degrees. It'll be on our YouTube page. So there usually are lots of listeners who listen after the podcast. So this will be available. I want to really thank you for your expertise and your time. It was really wonderful to have you on. And, once again, the message is to everyone listening, please get vaccinated, please. And please, everyone, stay healthy, stay safe, keep wearing your mask, social distancing, and we'll see you again in 2 weeks at our next podcast.
Thank you.
Take care.
Thank you, Nancy. Bye-bye.
Bye-bye.